هلو هلو.
اهلا يا بروف.
ايوه
هلو، حياك الله بروف.
الله يخليك. انا مش شايف الصوره.
ايوه حياك الله بروف. Can we open الكاميرا عندك الفيديو؟
الكاميرا ما كانت مفتوحه، انا ما غيرتش فيها، ما قفلتهاش.
من تحت
منين؟
كده كان ستارت فيديو او
منين؟
just click yes.
ستارت ماي فيديو. اوكي يس
كده ممتاز. طيب نكبر الشاشه يا بروف.
هي اوكي نكبر الشاشه. اوكي
كده ممتاز. احنا كده تقريبا 3 دقائق والستارت ان شاء الله.
اوكي
Dr. Ammar, welcome aboard.
Okay, we'll start.
Welcome everyone, and welcome to our special guest, Professor Ahmed Ammar. Professor Ahmed Ammar is professor in Department of Neurosurgery, King Fahd University Hospital in Saudi Arabia, and also he is a member of Ethics Committee in World Federation of Neurosurgery, and also General Secretary of International Society of Neurosurgical Technology and Instrument Innovation. Thank you for your time, Professor Ahmed, and welcome everyone to our monthly webinar in World Federation Neurosurgery Young Neurosurgeon Forum. Professor Ammar.
Thank you very much, Ahmed. Thank you very much, Ammar, and also thanks to Angelus. It's an honor, definitely, to be invited to talk to you, especially to young neurosurgeon, about a very important subject, ethics in neurosurgery. Ethics actually is involved in every step of our practice, medical practice, every day. For a long time, bioethics have been traditionally written, taught, and discussed by philosophers and ethicists, and it's considered an elite subject for the philosopher. And the clinician, they were rather far away from this subject. But actually, we learned a lot from our mentors and teachers, the philosophers. And but we have some reservation. Their great efforts and noble thought, unfortunately, did not answer all the clinical questions which we daily face in our daily practice. Therefore, we thought it is mandatory for some clinicians to study ethics and really to find out how can introduce the principle of medical ethics to everyone in the hospitals, and how really to implement it, and how really make it as rules for our daily practice. The prospect of ethical implementation in daily practice is very wide, and as I said, it actually involves every step in our daily practice. Talk about the patient, as it is the main important issue, or is a main target in our practice, that is for decision making. When you decide patient operate, not operate, treatment, which approach, whatever, this is not only clinical decision, but also ethical decisions. When there is a priority of admission, and for priority for surgery, and even life-saving and triage, this is also ethical questions involved very much. The consent and the informed consent, it is ethical question. Autonomy, the patient tries to refuse, accept treatment, to know about who is treating him, and this is absolutely ethical. One of the principles actually of ethics. But also, as we see, the diversity of management. And as we could see, there is this one method of treatment could be right for one patient, but not necessarily right for another patient, not only for medical indication, but also for ethical causes. One of the character of our medical practice, especially of especially dealing with serious diseases, is predicting the outcome. The rule is we are certain about uncertainty of many outcome of serious patients, what we call it medical ambiguity. So what do you do if you want to explain this to the patient? Ethics of evidence. When we try to explain, we try to go for evidence. But what is evidence? And what is the ethics of evidence? And how ethical or not ethical an evidence could be? This is very important and ethical issue. Another issue which we face from time to time, several times, maybe a week, about holding or withdrawal medication or denying surgery or brain death. All this have ethical impact on the clinical practice. Relationship with the family, with the patient family, and the patient privacy. This is also ethical questions. The quality of life, how you considered, and the value of life. Also ethical questions. Rehabilitation, healthcare resources, and justice and distribution of the healthcare resources. This is ethical question as it is healthcare system problem. Research, innovation, invention, new technology, all this also, rather than it is medical, practical skills, but also ethics have a lot to do with this, all of these issues. Medical litigations, ethical playing a very important role, ethics playing a very important role in it. Career development, first operation, when to stop treating a patient. These are also very important ethical questions. Work environment and the relationship between the colleagues and the administration. Ethics has a lot to do with this. Training, supervision of programs, and publication, and many others. So I would like really to agree with you about one language, and so we would like to define the things so at least we can talk about the same thing. What is ethics? It was said good facts leads to get good ethics. That's very true. But what is good ethics? Is it what we believe? Or is it what we practice? Or is it what we understand and interpret? Or is what we value? Is it the ethical behavior, or ethical thoughts, or individual ethics, or it is a group ethics? And what is value? The best definition I read by Brian Dyson, value is value when its value is valued. So only when you value a value, it becomes a real value. So value, even it is the same value or the same principle, but can be interpreted differently and can be also practiced differently. And this leads us to go for a very important ethical issue or ethical subject, what we call ethical relativism. The theory, we defined it as the theory which claims that because different societies have different ethical beliefs, there is no rational way of determining whether an issue is morally right or wrong. What is considered morally accepted or desirable in one culture, country, religion may be ethically unaccepted or unacceptable or undesirable by others. Let us see how the progress and the emerge and the evolution of the principle of ethics through the years, through the centuries, actually. Because when we talk about ethics and talk about implementing it and to talk about it, we have to talk about the principle of ethics, the pillars of ethics. Early years, 1,000 years ago, that is all the things related, all the issue related to the patient feeling, patient dignity, patient culture, patient belief, as a part considered as under big title, humanized medicine. So the culture, in fact, what was, and still, the culture's values and the ethical principles regulated and guarded the medical practice in all the civilization as they are doing now. We can see clearly in all the Chinese civilization, in old Indian civilization, in old Egyptian civilization, the ethics and the value and the culture played a very important role in the management of the patient and in the selection of the treating or the healthcare provider or the doctor, if we can call them doctors, who are really responsible about treating patients. This is a very important subject. Still, actually, we are not very far from them. But if we go for our modern medical principle, ethical principle, the roots goes to Hippocrates. And actually, Hippocrates, and in Hippocratic Oath, which all of us are aware about, he stated two important facts or two important principles. One, first, do no harm. Second, do good for patients. And that is stated clearly. In the Latins, non-malfeasance, do no harm. Beneficence is do good for patients. If we talk about non-malfeasance, it means, as if you translate from Latin, one ought not to inflict evil or harm. In our language, treating physician or surgeon should not cause any harm. Beneficence, one ought to prevent evil or harm. One ought to remove the cause of harm. One ought to do or promote any cause of harm. Do the best for patient. These were actually the first two ethical principles, and it remained like that for nearly more than 2,000 years. Then in the 19th century, the concept of patient-centered of care was emergent. And actually, that principle, patient-centered of care, was in accordance with the principle of medical ethics. The concept strives to improve the healthcare quality through integration of the patient values into or in medical care. We jumped tens of years till recently, and we find the most famous and popular ethical principle are the four principles which Bishomp's principle of biomedical ethics, which was written by Tom Bishop and James Childress, and published first by Oxford in 1985. There is a second edition of the book, also published by Oxford a few years ago, I believe it's 2002. It's a great book. They made four principles. First, respect of autonomy. Second, beneficence, do good for the patient. Third, non-malfeasance, do no harm for justice. But the American Psychological Association came up with another 5 principles of ethics. And they called it A, B, C, D, E. Principle A, they put the non-malfeasance and the beneficence together, the beneficence and non-malfeasance. B, fidelity and responsibility. C, integrity. D, justice. E, respect for people's right and dignity. That was not the only additions. Then the people of public health, Peter Schroeder back and his colleagues in 2014 came with another, what they call it, 7 principles of ethics. Again, non-malfeasance, beneficence, health maximization, efficiency, respect of autonomy, justice, and proportionality. These are almost, it is almost talking about the same thing, but from the first 4 principles, which made by philosophers, great philosophers, tell the people in public health, this is maybe something they have to emphasize in their practice as psychologists and as others, even surgeons. Recently, I came across about a general surgeon, I guess from Scandinavia, or I don't remember. He make it very clear. It's only one principle of ethics, patient first. But this is actually the implementation of ethics. It's not a principle of ethics. But Mark Bernstein was a great neurosurgeon, and he is also has a master's degree in bioethics from Toronto. And myself, when we thought about writing a book about ethics and studying it and presenting it to our fellow neurosurgeon, we adopted 6 principles of ethics. Autonomy, as agreed with everyone. Beneficence, do the good for the patient. Non-malfeasance is also do no harm. Justice, And we emphasize on dignity and honesty, as dignity is a core of actually for ethics as treating the patients. From patient perspective, his dignity has to be preserved. Honesty, it is absolutely important for neurosurgeon or doctors or physicians to be honest with the patient. You cannot be a good doctor if you are not honest. Absolutely honest. We integrated all these different experiences and with patient values and education, and we came up with value as a concept of values-based medicine. Actually, it was there, that terminology, but we made some modification to it or update to it. If we look at it, this algorithm, which you're representing it, we find that patient is the center of care. And if you would like, or you must, or you should, and this is also from principle, do the best for the patient, do good for the patient, you have to improve your knowledge. And here comes evidence-based medicine and update it and gain special skills in order to treat the patient properly and also use the technology and the research. All this will allow you to make a plan, a good plan for the surgery to provide best possible treatment for the patient and to make a strategy for the long-term outcome and actually that to answer some of ambiguity in the medical terms or in the medical outcome. All this has to be performed within a rigid frame of ethics and values. So our definition of values-based medicine is a concept to ensure that the principle of medical ethics is strictly implemented and observed in every step of patient's management. Values-based medicine is the integration of patient preferences into clinical practice. Values-based medicine has emerged in order to stress the medicine based on values as well as it is based on research evidences. I have a quote from that book about neurosurgical ethics, which published in November 2014 by Springer. Market
Prof. Ammar? Prof. Ammar?
Hello?
Prof. Ammar.
Yeah.
أعتقد صار في disconnection. Can we share the screen again and we continue?
Okay. I have to go to where we were. Okay.
We lost you from the book.
Oh, yes. Yeah.
Slide 21.
Yeah. Okay. So if we go to the principles of ethics or ethical principles one by one and try to see its impact on our service and how we implement. Autonomy. Simply, it is the patient has the right to refuse or choose the treatment. But it's not simple like that. It also has a lot of challenges in implementing it. The culture of the patients has to be considered. Social and family ties. Some members of the family, they don't like to make a decision without getting all the family involved. This also has to be respected. The age, geriatric, pediatric, neonates patients. Do they have autonomy or no? This is also an ethical question. Psychiatric patient, psychological patient with psychological disorder. Patient even very intellectual, very well educated, very independent, but in the time of facing this, became panic, became stressed, maybe unable to take a right decision. So is it right for him at that moment to take a decision or make him relax before taking it? And so on. So actually, rather than it looks simple, straightforward, but there are many changes, many challenges in it, and this should be considered. But in our mind, in our understanding, at the end, patient has the right and has the final say. With the patient, for a long time, that is, a lot of literature have been written about patient-doctor or physician-patient relationship. But actually, we consider it's more complicated than that. It's physicians, patient, family, complex relationship. Yes, in adult patient, the communications between physician, surgeon, neurosurgeon, treating doctors with the patient should be direct. Nobody should be in the middle. But is it the reality? In most of cases, yes. But the family, the loved one, they have a great influence. They are directly or indirectly involved in every decision. And this is, we should not turn a blind on that fact. And in the children and pediatric cases, you cannot really reach the children without going through the family. So this is also very important. But here, there's another important question. Minor, till which age? Is it 18-year-old who makes the decision? But what about intelligent, intellectual, 14-year-old who knows everything about his disease and wants to make a decision indifferent with the decision of his parents? Would he make that decision? Would you accept it? I think this is an ethical issue and could be accepted in certain cases. Then, if the patient wants to accept or discuss or agree about any sort of treatment, he has several questions. Most important question, what is the outcome? If the treating surgeon or the neurosurgeon or physician or medical or oncologist is not sure or uncertain about the outcome, how can you convince him to do or to agree about something you are not sure about? This is very important ethical question. So is it ethical to influence the decision of the patient? Patient seeking facts in order to make a right decision. And then the fact is, very few class A evidence about the outcome, definite outcome of some of the very serious medical problems, severe head trauma, sort of glioma or skull base, many things. But unfortunately, this is one of the unfortunate situation all of us may find themselves trapped in. The neurosurgeon in that situation have two options. May emphasize, they try to be very honest, emphasize about the uncertainty or practicality. But this makes the patient confused and may ask second opinion, and may the patient lose the trust of the treating physicians. Rather than you try to be honest, you try to give all the possibilities, all the answer up to your knowledge. Others, they emphasize on certain known management and the outcome according to their own accumulated experience. This is also ethically questions because you don't give the patient the full scope or the full picture of it. I don't want to confuse you, but this is a real situation to show what is the ethics it should be. Ethics in this case, understanding the core of ethics, that is your attentions and your target and your consideration is for the patient safety and the patient best interest. You do, you suggest, you discuss, you answer only out of these motivations. So we touched about evidence-based medicine and we talk about values-based medicine and the ethics. Is there a conflict? I don't think there is any conflict and shouldn't be any conflict. As real evidence-based medicine in our definition is a part of values-based medicine. But actually, there are other philosophers, they consider and ethicists consider ethics as a part of evidence-based medicine. Whatever it is, both of them are related, strongly related. But when we talk about evidence, how we define evidence? How we define, under which criteria is that evidence? Evidence of treating group A with certain medication can have good result, but is group A is the same as group B and C and D? So there are many issues about this and what constitutes acceptable evidence. And this is also a very philosophical question. We cannot leave the autonomy without talking about the brief about patient rights, which you see it everywhere in most of the hospitals in the world. Simply, patient has the right for good and fair treatment and follow-up. He has the right to be partner in making a decision and the right to refuse treatment. He has the right to consent for every step of treatment. He has the right for confidentiality, privacy, and dignity. He has the right to be educated about his disease. He has the right also to complain against the doctors or the hospital if he feels there's something wrong went with him. Doctors, neurosurgeons, they have the duties and tasks. First duty to respect patient rights, to be honest, to do the best for the patient, their best for the patient, to be available for discussion, to stay current, to train themselves, to continue educating themselves, to gain new skills, to recognize the new technology and know how to use it, to train residents and expand the knowledge to new generation, to do research and to work in team. Doctors have right too, not only the patient has right. Nurses, they have rights. Paramedics have rights. Everyone has rights. Doctors have right to be respected, to have right to have private life. They have right to continue their medical education. They have right to use new technology. And they have right to be supported by the hospital administration colleagues if they are in trouble. They have right to do research. They have right to have good and safe working environment. They have right to share in the hospital decision. And they have the right to a reasonable outcome. We go to the second principle, beneficence. It means do good for the patient. Act in and for the best interest of the patient. It is the obligation to help imposes on healthcare practitioner, that is to promote health and welfare of patient above other consideration, while attending and honoring patients' personal autonomy. Just an illustrative case, just to highlight this position. As all of you know, decompressive craniotomy. You know, it's an operation done everywhere, but what is really the value? In some cases, like this case, we can see clearly patient has middle cerebral artery stroke. He was shifting of the midline. He has hemiplegia. Pupil started to get dilated. He is rushed to decompressive craniotomy, was done, and he showed some improvement. However, he remained have left side hemiparesis, but he was able to talk and to manage, sort to manage his life. It's the same picture if the patient has severe head trauma and severe contusion. The studies from Cambridge, for example, if you treat them, if you don't treat them, the patient die within 6 months or immediately. But if you do decompressive craniotomy, they may survive, longer survive, but the quality of life will not be very good. So here is this question of the value of life and the quality of life. Very important ethical question. Here, if we go to the third principle, non-malfeasance, it means do no harm. This also came from Hippocratic oath. But again, what is harm? Is it the expected or not expected complication? Is it the clinical worsening or deterioration of the case? Is it an error or a mistake has been done during the treatment? Is it the negligence of the case? Is it the violation of the patient rights? In every step, in every kind of treatment, patient safety should be guaranteed. But for you, young neurosurgeon, for first operation, for first use of technology, there is a frame of patient safety has to be observed. That is, shouldn't do the operation alone in the operating room. And guarantee patient safety before the anxiety or before the will to do first operation. There are actually different perspectives of non-malfeasance and malfeasance. As long as you read, discuss. The philosopher, they may look at it in one way. The neurosurgeon and the practitioner or physician who are really their hands wet with the patients wet in the world are also, may have different perspective, but also patients may have completely different perspective. Maybe he feels what is good for him, maybe it's not the same as the philosophers think about or treating physician thinks about. Justice. This is a very sticky subject. But also, justice was emphasized in all the ethical principles have been discussed from 4, 6, 7, whatever. It means patient has one of the fundamental human rights is the right of the patient to be treated. So it's the right of the patient to be treated. But which kind of treatment? We know the social and health economy and the cost, and we see the distribution of the resources. We cannot say that the patient in every hospital has the chance to be treated the same. If you have a limited resources, how can you distribute this limited resources to cover most of your patients? It is also a very important issue. But even if the limited resources are available, or the resources are available, some patients, they need extra service. Is it ethical to give them the ethical extra service if sometimes they think they deserve it on the cost of poor patient who may not get the treatment? This is very important and practical ethical questions. We know that the modern medicine is advancing very rapidly. We know that technology is overwhelming the resources and very expensive. So it is necessary for healthcare system planner to use what they call the cost-benefit ratio analysis, determining what beneficence, when beneficence ends and malfeasance begin, when the good service start before causing damage or harming to the patient. This is a practical solution for the problem, but is it ethical? And how can we approve it? Justice in healthcare system has three items. One, what we call procedural justice, is the idea of fairness in the process of distributing allocated resources. Distributive justice, how to distribute the resources among the community, or among the nation, or among the world. Substantive justice is the just behavior or treatment that fair and reasonable. Come to the dignity. We choose to add dignity to the four. The first four principles are as Bishop principle and other, but we actually decided to add dignity as a separate principle because dignity is considered is the core of ethics as we believe. Dignity is defined as considered with how people feel, think, and behave, and when they worth or value of themselves and others. Dignity should be spelled out clearly to avoid any ambiguous or vague or application or understanding among the hospital staff. Patient dignity is central of ethical medical practice. Patient dignity is not only a basic human right, but also very important to ensure that the patient will follow medical instruction and obey for the order. And that's why the best outcome can happen. If the patient feels that you don't respect his dignity, he will never listen to you. So this is also a part of the treatment. The last one of the principle is honesty, truthfulness and honesty, in which the relationship between the patient and treating surgeon should be based on unconditional truthfulness and honesty. The neurosurgeon should answer every patient's question honestly and should admit openly any mistakes made. This is absolutely important. If we look at this, and maybe after you reach with me this part of the lecture, you say, there are a lot of confusion. There are a lot of conflicts between the principle of medical ethics. Is it possible to avoid it? Actually, it's not. If we really understand and digest the spirit and the soul and the core of ethics, as we are targeting the patient, as the patient is our main concern, is the patient of the center of care, that is all this confusion will be dissolved. So, for example, autonomy and beneficence. One can say, patient has a serious problem, and you offered malignant tumor, for example, or abscess or whatever. You recommended surgery, and do you believe this is the best for the patient? And the patient refused the surgery. So what should you do? Is this a conflict between the autonomy and beneficence for providing the best care for the patient? No, but there are ways to deal with this. You can explain to the patient again and again in his language to can understand why he is refusing. You may get involved, be other people involved. There are also people say a lot, and this is discussed about conflict between beneficence and non-beneficence, and when the no harm starts and when the good treatment for the patient ends. For example, trial or new medication or new surgery or new equipment. We believe it would be good for the patient, but it's never been tried before. How could you know it will not cause harm unless there are certain safety frame and the trial? And comes from the ethics of research. Also, between justice and beneficence, as we discussed before, if, for example, patient needs very expensive medications, gamma knife, and the resources are not available, is this a conflict? No, it's not a conflict. Still, justice as principle of ethics, which should be respected and should be worked for. And beneficence is you do your best within the limited resources you have. I give an illustrative case about this. Just few illustrative cases, 3, to demonstrate this kind of conflicts. 63-year-old was admitted with severe dorsal pain and paraparesis. MRI showed dorsal 8, 9, 10 tumors. We offered him surgery. The patient refused surgery. Okay. Here, what shall we do? I think the first thing is that we should not look to convince the patient. We should actually go very deep in that problem and ask why the patient refused treatment. Is the patient refused treatment because he is fed up and wants to die? Is he refused treatment because he is afraid from surgery? Does he refuse treatment because he is very scary or he doesn't trust the people? So I have to find out the reason why he refused the treatment and then try to convince him and answer it. Then if we've tried and failed, is it possible to waive one of the patient right, confidentiality, in order to solve this problem? Yes, we can do it, and in the same time, we preserve the patient rights for confidentiality. We ask him, would you like to get someone of your family to be involved in order to help you and help us to answer this question and find the best way for you? Actually, many of these patients, they would like to do that. And this helps and solves the problem. As this solved it, and his cousin involved, and he was operated. Case 3, this is very important issue, and we talked about it several times. Now we are talking about a medical terminology. This is a patient, 46-year-old gentleman, visited one of the OPDs complaining of low back pain. He had history of L4-5 microdiscectomy 18 months prior to that visit. Post-operatively, he was fine for 1 year, then the pain started to bother him again. He came to the clinic to ask, he went to that clinic, he asked a second opinion, and he was told he had filled back surgery syndrome. I believe that is the surgeon, the neurosurgeon, when he answered him, he just used the right terminology, didn't make any, the common terminology, didn't want to make any problem. But the patient was very upset to hear that, was very angry and was depressed. And he started to blame his previous surgeons and neurosurgeon. And he started to lose the trust of everyone. And that is because of, if you translate the words failed back surgery syndrome, it means that your previous operation failed. Your operation is a failed surgery. Your back suffered of failure. Who is then the question, who is the cause of that failure? So that is really has a lot of psychological impact on the patient. This is the same patient. He had this, as you see, right lateral L4-5 disc. The operation to the right is, you see the disc was completely removed, beautifully removed. But there is the track of the surgery, there is adhesion, post-operative adhesion, which caused him the trouble. And this is one of the causes of that problems. Okay. I wondered several times. We have that terminology, failed back surgery syndrome. Why there is no failed cardiac surgery syndrome? Why there is no failed hepatic surgery syndrome? Why there is no failed renal surgery syndrome? Any good thing that terminology gives the patient or the doctor or the medical student? This terminology should not be used at all. It is unethical terminology. This terminology causes more harm than good. It disturbs the psychological status of the patient. Not only that, it may wrongly indicate an error of the previous surgery and cause troubles for the other surgeons who did a really good job. So this terminology, I really believe it shouldn't be used. It is unethical terminology in our daily practice. Last case, we have also 4-year-old patient, a child, has been complaining of headache and right side hemiparesis and lower cranial nerve palsy. MRI showed brainstem cavernous angioma. We offered the patient surgery. We offered the surgery for the patient and discussed it with the parent. The parents were very worried and concerning about the patient, and they started to ask questions. They were blunt, and they asked, "Can you do this surgery? Is there other better place than this here to perform that surgery?" Some neurosurgeons, they get irritated or they don't like this question. But I believe it's very important to respect every question the patient or the patient family have. This is ethics. This is autonomy. Patient has the right to ask. And our obligation, our task and duty to listen to the question and honestly, probably answer all the questions. And actually the patient and the parents sometimes, most of the time, they have sense. When they feel the sincerity and honesty and you are transparent and discuss, they will accept and trust you. And this is building the trust between the patient and the patient family and the neurosurgeon or the treating physician is one of the fundamental principles for the success of the treatment. And that's which remains. That's what makes the patient follow the order and treatment and reflect on its outcome. This is very important issue which should be respected, the communication and the honesty and answering and responding to the question. Anyhow, the family agreed, patient was operated, as you see, and actually he did good. Our conclusion: ethics is a complex field. Over thousands of years, humans have yet to develop a theory to satisfactorily handle all issues of healthcare. Medical ethics, although generally universal, are interpreted differently in different places and different cultures. Values are also relative to that values-based medicine, so that value-based medicine is subject to relativity, religious beliefs, culture, milieu, politics, laws, geography, and others. There's a clear ethical relativism in that what is considered more acceptable or by one culture or country or region may be ethically unacceptable or undesirable by others. Bioethics should be a part of the curriculum of all medical schools. Some approaches have proven to be more satisfactory than others and have led to develop ethical principles. We should really, it doesn't matter which type of ethical principle you may use or follow or teach, as long as the core, soul, spirit of ethics well digested and understand. And you put all the time patient safety, patient well-being, patient interests before everything. And everything you do, even your training, even new skills you do, even conference you go, and learning. That is at the end to reflect on your way to treat the patient and give him the best possible health care. There is a great need to include values-based medicine and bioethics and medical ethics in every medical and surgical and neurosurgical training program. Thank you very much.
Thank you, Professor Ammar, for your great time and great lecture. It's really an important topic. We face it in every case. We will open the floor for question, and I think Dr. Salah Al-Aqad, he wants to ask a question, so we'll give the mic for Dr. Salah. Dr. Salah.
Hello, سامعينني?
Oh, yes.
Okay. This is an important subject, and I have a very important question. After all this discussion, we live in a culture where before I give the diagnosis to the patient, in many instances, the family comes and said, did you tell him about this diagnosis? If I say no, he said, please don't tell him. And they come like the whole tribe come and surrounding me, okay? And to the limit that occasionally this can cause troubles. What we understand that the patient has to know. And unfortunately, in our culture, in many instances, we get resistance from that. So what shall we do?
Well, that is what we talk about. There are actually differences, but still remain. Patient has the right to know. At the end, you talk with the relatives, the father, mother, parents, friends, whatever, and you convince them patient has to know. That is the best way of treatment. I cannot take the patient to the operating room without telling him that he has something to be operated for. Basically, he will not be hurted. Let us have a conference, sit all of us together, and we talk to the patient and give them the facts in simple way. But patient has the right to know. This cannot be denied. So I passed this, and I was involved in this discussion several times. But the end, I really insist that the patient has to know. You know, it is different between how to present your case, how to tell the truth. I remember now very much, just occurred to me, Professor Lixal. That was a long time ago, over 40 years or something like that in Kauneska. And actually it happened that he had a patient, he had a brain tumor. And he was young, panic, and things like that. And Lixal, the patient asked what he has. He told him that is you have like a ball in your head, and we would like to operate you and take it out. He didn't lie. He avoided to mention the tumor, consider it manipulating the words or no, but at the end, the patient signed and get the operation. But that was 40 years ago. You cannot use this now. If you cannot use ball or cyst, you can use that is, yes, you have a mass lesion. This could be tumor, could be something else. And really, it's possible to be treated. There are things, possibilities. You don't give final outcome, final decision, and go for surgery, but patient has to know. Is it okay, Dr. Salah?
Yeah, I understand this. المشكلة إنه لما بيكونوا في ناس غير متعلمين يا دكتور بيسببوا لنا مشاكل كبيرة جدا.
دكتور صلاح.
أيوة سامعك. أيوة.
Can you speak in English? We have many people who are non-English speaking.
Yeah, sorry for that. But, you know, my question is that we live in a community. Some of them are really very simple people, but they have some sort of rules in their families, and they can cause lots of troubles for us. And here, do we have like what I understand that we are legally obliged to talk to the patient, okay? But how can we protect ourselves? I don't want somebody to show me, to strike me with a knife or something like this.
No, it will never go like that. How do you discuss with the patient? The maximum thing, if you insisted to the family that you would like, that is, you have to tell the patient, and we sit together and we tell them in the most simple way, but straightforward, with, you know, not scaring, but just give him the truth. They have two choices, either to accept or not to accept. If they accept, that's good enough. If they will not accept, they have the right to take their patient to another doctor or another one. So that is, but they would not attack you for any reason. So that is, has to be, if you find all the doctors around in the area, they have the same principle. Patient has the right to know. At the end, they will learn in the lesson. It is one part of the patient right and patient family right to be educated. It is only the hospital also a place for education, for not only the doctor and young doctor or young nurses, it's also for education for the whole society and for the patient and the patient family as well.
Prof. Ammar, I have a question.
Yes.
Some cases we face it in our specialty. We put the patient DNR, do not resuscitate the patient.
Yeah.
The question that it is a purely medical decision, it's not to resuscitate the patient, but should we take the permission from the family or just to inform the family that we are not resuscitating?
You should inform the family and you should get the family involved in the beginning. That is, you have to explain to them why you take this decision. It is for good medical reason, for the quality of the life, for there is no hazy or not clear outcome, good outcome for the patient, or the evidence doesn't support that the patient will come out of it. Many reasons you get the family to be involved first, but you don't, ethically, it's not right to make the decision and then later on to inform the family. No, I don't agree. Some people, they do it, I see, but the point here comes important ethics. What we call it is the ethics for the society or ethics for individual. The people who say you should do it, when they considered, for example, the patient, the ethics for the good society. For that's, for example, the bed has to be used for another patient in need for that. Many things like that. But if you talk about individuals, in this case, you have to get the family involved. Actually, it may delay the decision for few days, but it is at the end, it is far better. That's to get the patient and the patient family involved, discuss with them several times, discuss with a group of them, discuss with the social worker, and at the end, they will agree. I have been in the hospital for many, many years, as you know, and yes, at the time we have at the beginning resistance, but at the end, they agree.
Thank you very much, Prof. Amjad, do you have a question? Amjad? Alam, do you have a question? Alam?
Hello?
Yeah, go ahead.
Can you hear me?
Yes, we can.
Yes. There are some situations whereby patients are not fully aware of the circumstances. For example, a patient may have a Karnofsky score, which is around 70 or 80. And explaining to the situation to the patient will be very much difficult. So in that case, is it only enough to explain to the family on the situation and then go ahead with the surgery?
Yes, this is right. If the patient, as we said, he is unconscious, he is comatose, he is confused, he doesn't understand, he is under influence of drugs or alcohol, and you need to do life-saving procedure. You don't wait for the patient if it's necessary, and you get approval and consent from the husband or wife or father or mother, first relatives, and this consent has also to be signed by the another consultant or the medical administration. So that is, you don't wait for the patient to wake up or condition improved to explain to him in order to perform life-saving surgery or important surgery.
Okay. And on another point, on the do not resuscitate, should it be only a neurosurgeon who should be focusing and discussing with the family, or should we involve the critical medicine people and also the intensivist in the ICU and also the treating head nurses as well?
Actually, this is the people who start to initiate the discussion with the family is not the neurosurgeon, the intensivist, because they are the people who are treating the patient first. But the neurosurgeon has to be involved. It should be, the best way that is neurosurgeon. It could be a meeting. Neurosurgeon, the intensivist, nurses or social worker, and several members of the family, and sit together, discuss the case in details, answer every question, give them enough time. You don't meet them in the corridor and just tell them, say, well, we will not resuscitate the patient. Take them to the room, sit with them, make unlimited time for the meeting and answer. And I believe in this way, you will get their approval.
Okay. Thank you very much.
Thank you very much.
Very welcome.
Any further questions?
I have a question. Just Professor Ammar, would we do not resuscitate? We are explaining to the family to make them understand the situation, but we will never take their approval. If we want to take their approval, they will feel guilty and they will never approve it. We tell them this is a medical decision. We gave them our why we are doing this, yes, but to take their approval is extremely hard. What do you think?
No, it's not approval to do it, but that is at least they should be aware and they know that in their heart they agreed. There are differences between agreed upon certain procedure or approve certain procedure. Very philosophical lines between them. So you cannot really say, I am not going to resuscitate the patient and the family are jumping up and down, do your best for this patient. Okay, but you can do it. Don't resuscitate the patient, and the patient, you explain to them and they understand the situation and they agreed. That is coming to the end.
Okay.
Thank you very much.
Thank you.
Any comment, Dr. Ammar Habib?
Well, thank you very much, Professor. These are sometimes very difficult points to swallow. And maybe if I know your kindness, Professor Ammar, that we can invite you again for probably another discussion or case-based discussion later on sometime in our webinar. Thank you for a great talk.
Thank you very much. It's always a pleasure to be with you, and I'll be more than happy that is to have another webinar based on real cases.
Thank you very much, everyone. We have our previous webinars in our YouTube channels, and we will announce for monthly webinar, inshallah, in the future. Thank you very much, everyone, and thank you, Professor Ammar. Have a nice day.
Thank you very much. Thank you for all the people who listen to it, and hope to see you again.
Thank you.
Bye.
Thank you very much.
Bye.